It's a great honor to participate in such an amazing event, highly scientific event, and many thanks for Dr. Nada and the organizing committee for the kind invitation. Now we are talking about the endoscopic classification of our IBD patient.
You have 15 minutes, Mohammed.
Okay, Doctor. Although the advances in the biochemical and the biomarkers and the radiological investigation, the patient of IBD, the endoscopy and the colonoscopy remains the gold standard. Okay, so it's not just a matter of diagnosis. It's diagnosis, monitoring, and the management plan of IBD. It's related to the endoscopy. So I think we all feel this situation before. We have a patient which is symptoms-free, having clinical remission, but you are doing endoscopy, you found this lesion. So the STRIDE 2 trial had changed the plan, and you have not just short-term target, you have the short-term target and intermediate target and long-term target, and long-term target are concerning about achieving endoscopic and the mucosal healing. If you don't reach this target and you don't achieve the endoscopic and the mucosal healing, you will change the plan. So the endoscopy and the endoscopic scoring is very important during the management plan of IBD patient, and you may change all the course of management according to the endoscopic management. Okay, what about the ulcerative colitis and endoscopic classification? Endoscopic classification of ulcerative colitis, it's mainly concerned about the extent and the severity. So when you are describing the extent of lesions of ulcerative colitis, you may use the Montreal or Paris classification. E1 in H classification, it means ulcerative proctitis. E2, it means left-sided lesion which is limited to the splenic flexure. E3 in Montreal classification, it's limited to any lesion extended behind the splenic flexure is E3 in Montreal. But if you are using Paris classification, E3 extending from the splenic flexure to the hepatic flexure, and the E4 is any lesion extending behind the hepatic flexure. So the difference between two classification is among E3 and E4. E3 in Montreal, any lesion extending behind the splenic flexure. E3 in Paris classification from the splenic to hepatic, and the E4 is the colitis. So what about the severity? Many systems have been validated, but only the myo-endoscopic score and the ulcerative colitis endoscopic index of severity are validated and used in clinical trial and both in clinical practice. So to understand about each system, to use each system, you are going to focus in 3 points. What about the mucosa? What about the vascularity? What about the covering and friability? Mucosa, vascularity, covering and friability. And if you are going to describe the mucosa, look to the color, to the surface, is it granular or smooth? To the ulceration and the erosion, is it present or not? So let's go to the ulcerative colitis endoscopic index of severity. We have 3 descriptors: the vascular pattern, the bleeding, the erosions. For the vascular pattern, is it graded from 1, 2, and 3? 1 is normal, 2 is patchy obliteration, 3 is fully obliterated. Bleeding, 1, 2, 3, and 4. 4, it's mean luminal bleeding, frank luminal bleeding. 3, just spots in the lumen, and 2, just a mucosal bleeding, not a luminal, not a free passage of blood in the lumen. And the erosions and the ulcer will be classified only from 1, 2, and 3, and 4. You have the 3 descriptor, and will sum the sum of the 3 descriptor where in the worst affected area during colonoscopy. So you are during examination, you have the most affected area, and you have the 3 descriptors, and you have the sum of the 3 descriptors. That is the ulcerative colitis endoscopic index of severity. Back again to our lesion: mucosa, vascularity, friability, color, surface, and ulceration. The Mayo endoscopic score, no much numbers, it's just 4 numbers: 0, 1, 2, and 3. If you're having an ulcer, the ulcer go directly to Mayo endoscopic score 3. If you're having no ulcer, it's 0 or 1 or 2. If you're having a marked erythema, it's Mayo endoscopic 2. Mild erythema and the granularity, it's Mayo endoscopic subscore 1. If there is no any erythema and the normal mucosa, it's Mayo endoscopic 0. Again, if there is ulcer, you are going to Mayo endoscopic 3. No ulcer, it's 0, 1, or 2. Marked erythema, it's 2. Mild erythema, it's 1. No lesions, it's 0 classification. What about the modified? For example, this lesion, if you are looking to figure D, there is erythema, diminished vascularity, but no ulceration. So this scoring is Mayo score 2. This lesion is having an ulcer, so it's Mayo score 3. The modified Mayo endoscopic score, you will have the Mayo endoscopic score applied to each segment. So you're having a 20 points modified Mayo endoscopic score. You will apply the Mayo endoscopic score, but to each segment of the colon, except the ileum. So the modified Mayo endoscopic score have high correlation, not just with the clinical remission, but just with the histological remission. Don't forget that Mayo subendoscopic score is a part of Mayo score of ulcerative colitis, which depends on the stool frequency, rectal bleeding, and physician global assessment. Mucosal healing. Mucosal healing in Mayo endoscopic score, it's varying from 0 to 1. But it's better to achieve 0 level. At 0 level had better prognosis and less incidence of recurrence. This table shows the frequency of use endoscopic scoring among clinical trials and shows that the Mayo subendoscopic score should have a priority in all clinical trials have been done. What about Crohn's disease? Crohn's disease, is it classification to describe, is it oleoclonic disease? Or we are having a system classification for post-surgical Crohn's disease or anal Crohn's disease? The global evaluation of lesion severity passing through levels. First, you have to describe the number of segments exhibiting the lesion. Then, in this segment, you will search for average surface area affected by the disease as a whole. In this segment, you will search for average surface area involved by ulceration. Then, if there is stenosis or no. Again, first of all, number of segments affected by Crohn's. Then the total area affected by the disease, average surface area affected by disease through the normal human, then the ulcerated surface area, then a presence of ulcerated or non-ulcerated stenosis. The endoscopic appearance of stricture may be short or long, mild or severe, inflammatory or fibrotic, ulcerated or non-ulcerated. Presence of ulcer at the stenotic area does not just mean an active disease. It may mean surgery-associated ischemic ulcer. The validated endoscopic scoring system is the Crohn's disease endoscopic index of severity and the simple endoscopic score of Crohn's disease. They are validated, but the advantage of simple endoscopic scoring system is it practical, is to be applied, not just difficult, that's Crohn's disease endoscopic index of severity. The Crohn's disease index of severity. First of all, we will define the colon to 5 segments. And we will describe if there is deep ulceration, it will have 12 degrees and 0. If absent, superficial ulceration, surface affected in centimeter, and the ulcerated surface. We will describe and put all the marks for each segment of the clonic segment examined. And this will give us a total number. This total number is we'll call it total A. This is not just the scoring which will end on here. We have the total A number and divide it into the number of segments have been examined. So we're having A divided into N will give total B. Total B will be summed on the ulcerated stenosis if it's present or not. Ulcerated stenosis if present to have 3 degrees. If it's absent, it have 0. This is total C. Non-ulcerated stenosis present have 3 marks. Not present have 0 marks. Total B and C and D is the sum of Crohn's disease endoscopic index of severity. Again, B is A divided on N, and N is 1 and 2 and 3 and 4, which is number of segments. This is an example. We're having this deep ulceration and superficial ulceration, surface affected. We will have the sum of each segment. So we are looking, this is the sum of total A and then it will be divided in the number of segments examined, and we have C and D, and having the total Crohn's disease endoscopic index. What about the simple endoscopic scoring system? Simple scoring system, we have also the 5 segments of the colon. Then presence of ulcer, we're having 0 to 3. Presence and extent of ulcerated surface, 0 to 3. Affected surface, 0 to 3. Presence of narrowing, 0 to 3. So it must simple and be much easy to be applied. And the sum of each affected segment will be summed and have the total of simple endoscopic scoring of Crohn's disease. For example, there is C. C, we're having a stricture. If having a stricture, you're having a sum of 3 total. A, you're having a stricture with ulcer, you're having the segment having 3 marks for stenosis, and ulceration having 3 marks also. D, this is deep ulcer affecting more than 50 centimeters than 75 of the circumstances, so it having a grade C. You have to sum all of them, and you have the simple endoscopic scoring of Crohn's disease. Rodgert score is also described to post-surgical Crohn's disease. Perianal Crohn's disease having its endoscopic scoring, and the Crohn's disease according to the distribution, dominant and clonic dominant, and mainly and only clonic. In clinical trials, the simple endoscopic scoring system is Rodgert score is most commonly used among the clinical trials have been used to study the Crohn's disease patient. My home message. My home message, colonoscopy have been routinely used to diagnose and differential diagnosis, disease monitoring and assessment, and the treatment response in IBD patient. Various endoscopy disease activity instruments have been developed in Crohn's disease and colitis bursitis. These diseases activity indicators are mainly used in clinical trials. I wish that we're having a reporting system of colonoscopy that having validated an endoscopic scoring system among our routine practice to be validated, and we have agreed to as endoscopic scoring system and modify our reporting system of Crohn's of IBD patient for the sake of patient and clinical stuff. So thank you.